Good evening and welcome to this postgraduate course. I'm Dr. Quintin Babaran, a gastroenterologist, and I'd like to discuss with you this evening the topic on dyspepsia. For now, I have no disclosures to make. The learning objectives for this lecture are the following: that at the end of the lecture, participants will be able to define dyspepsia in the clinical setting. They should be able to distinguish functional dyspepsia from other disorders with similar signs and symptoms, and review the various clinical presentation of patients with dyspepsia and identify alarm symptoms that should prompt referral to gastroenterologists. And lastly, that they will be able to determine the criteria or clinical features that will warrant endoscopic evaluation of dyspepsia. So what is the best strategy for dyspepsia? First, let us define dyspepsia. Dyspepsia comes from two Greek words, which are dys and pepse, which literally means difficult digestion. In the current medical terminology, it refers to a heterogeneous group of symptoms in the upper abdomen. Dyspepsia is a presence of pain or discomfort centered in the upper abdominal area, with multiple and varying symptoms that includes epigastric pain, postprandial fullness, early satiation, anorexia, belching, nausea and vomiting, upper abdominal bloating, heartburn, and regurgitation. Note that nausea and vomiting and heartburn and regurgitation are highlighted in this slide because in the next slide, according to the Rome 1 and 2 consensus committee meetings, they define dyspepsia as pain or discomfort centered in the upper abdomen. And the discomfort includes postprandial fullness, upper abdominal bloating, early satiation, epigastric pain, belching, and vomiting. Again, note that belching and nausea and vomiting are highlighted because in the next slide, which is the Rome 4 consensus committee meetings, they eliminated the 2 and only 4 symptoms are considered specifically of gastroduodenal origin. These are postprandial fullness, early satiation, epigastric pain, and epigastric burning. When we speak of uninvestigated dyspepsia, it means that no diagnostic investigations have yet been performed and in whom a specific diagnosis that explains the dyspeptic symptoms has not been determined. What are the causes of dyspepsia? Dyspepsia are due to organic causes, due to food and drug intolerance. They may be due to biliary and pancreatic disease or some systemic disorders. Among the organic causes of dyspepsia, peptic ulcer disease comprise 5 to 10%, and gastroesophageal reflux disease about 20%. Other causes that are of organic origin are the presence of gastroduodenal neoplasms and erosive esophagitis or gastritis. Certain foods may precipitate or trigger dyspepsia. However, ingestion of specific foods like spices, coffee, or alcohol, or excessive amount of food has never been convincingly established as causing dyspepsia. Dyspepsia is also a common side effect of many drugs, including iron, antibiotics, narcotics, digitalis, estrogens, and oral contraceptives, theophylline, and levodopa. The mechanism of injury in these patients are due to direct gastric mucosal injury, or they may change the GI sensory function, or facilitate gastroesophageal reflux, and in some cases, the mechanisms are idiosyncratic. Functional dyspepsia, as described by the Rome 4 criteria, is the presence of early satiation, postprandial fullness, epigastric pain, or epigastric burning in the absence of organic, systemic, or metabolic diseases that is likely to explain the symptoms. This comprises the majority of subjects with dyspeptic symptoms, and no organic or abnormality is identified by routine clinical evaluation that includes endoscopic procedures. Dyspepsia is a symptom complex, and in the tertiary care center, the most frequent symptoms are postprandial fullness and bloating. This is followed by epigastric pain, early satiation, nausea, and belching. However, in the general population, the most frequent dyspeptic symptoms are postprandial fullness, early satiation, upper abdominal pain, and nausea. Dyspepsia is an overlap of symptoms of different GI conditions. And in patients with PUD and gastroesophageal reflux disease, dyspepsia may be a common symptom of the two disease entities. and it may be difficult to differentiate one from the other in the presence of dyspeptic symptoms. Gastroesophageal reflux disease has heartburn as a typical manifestation of the illness. However, dyspepsia may also be present in gastroesophageal reflux disease, and the presence of typical heartburn does not necessarily rule out dyspepsia. Let me just cite 3 GI diseases in which dyspepsia is a common manifestation of the 3 diseases. However, let us point to the typical symptoms of these illnesses. For gastroesophageal reflux disease, heartburn is a typical reflux symptom that radiates retroexternally. Among these patients with dyspepsia, epigastric burning pain is the cardinal symptom of their dyspeptic symptoms. And for patients with dyspepsia like IBS, their symptoms are relieved after defecation. The epidemiology of dyspepsia, it is common in the general population with a frequency ranging from 10 to 45%. It is more prevalent among women than men, and smokers and NSAID users are at higher risk to develop dyspepsia. The quality of life is significantly affected by dyspepsia, especially the functional type of dyspepsia. In the epidemiology of the disease, majority of the patients do not seek medical care. However, a significant proportion will eventually seek consultation, which results in substantial costs. The factors that influence healthcare seeking are the symptoms severity, fear of underlying serious disease, psychological distress, and lack of adequate psychological support. When we have identified the dyspepsia to be functional, we have to differentiate the postprandial distress syndrome from the epigastric pain syndrome. The postprandial distress syndrome is characterized by meal-related dyspeptic symptoms and postprandial fullness and early satiation. The epigastric pain syndrome is characterized by meal-unrelated dyspeptic symptoms, epigastric pain, and epigastric burning. How do you approach functional dyspepsia? We have to start with history and physical examination, taking into consideration the nature, the frequency, and chronicity of the symptoms, its relationship to ingestion of meals, the possible influence of specific dietary factors. We have to look for alarm symptoms such as presence of anemia, blood loss, and dysphagia. And we also have to determine the presence of comorbid systemic disorders such as diabetes mellitus, cardiac diseases, and thyroid disease. In the physical examination, we have to look for presence of abdominal mass, organomegaly, ascites, and even the presence of positive occult blood tests. For patients after the age of 45 to 55 or even older, a baseline CBC, serum electrolytes, serum calcium, and liver biochemical tests and thyroid function tests should be performed. In the initial management of patients with dyspepsia, both the primary care physicians and gastroenterologists should be aware that the patient's history and physical findings, and even the presence of alarm symptoms, are unreliable in distinguishing functional from organic causes of dyspepsia. There are 3 strategies that may be employed in the management of dyspepsia. First, prompt diagnostic endoscopy followed by targeted medical therapy may be performed. Second, non-invasive testing for HP infection followed by treatment based on the result of the test, or the test and treat strategy. And third, the empirical anti-secretory therapy. Let me expand this in the next slides. Endoscopy before any therapy has been instituted is still considered the gold standard for the diagnosis of upper GI disorders. The procedure may also have a reassuring effect on patients and physicians. And most guidelines and recommendations advocate prompt endoscopy when risk factors for dyspepsia, such as NSAID use, age above 40 to 55, and alarm symptoms are present. Patients older than 50 or 60 years old without alarm features, most guidelines recommend initial diagnostic endoscopy. And management will depend on endoscopic findings and detection of Helicobacter pylori. Proton pump inhibitor therapy is likely to be prescribed to most patients. Initial endoscopy may be associated with small reduction in the risk of recurrent dyspeptic symptoms, but this gain was not cost-effective. The next strategy is test and treat for H. pylori infection. Several consensus panels and guidelines have advocated non-invasive testing for HP in young patients, employing both urea breath tests and fecal antigen tests. The benefit of this test and treat strategy are the cure of peptic ulcer disease or prevention of future peptic ulcers and symptom resolution. In high prevalence areas, those with the 20% prevalence of HP infection, the test and treat approach remains attractive because patients with PUD will be cured. The next strategy is empirical anti-secretory drug therapy. Initial empirical anti-secretory therapy is widely used in primary care for patients with uninvestigated dyspepsia. In areas with low prevalence for HP infection, empirical anti-secretory therapy, usually a PPI, for 1 to 2 months is the preferred option. If symptoms persist or recurs after empiric treatment, endoscopic examination should be performed to rule out underlying illnesses. The approach is attractive because it controls symptoms and heals lesions in most patients with underlying GERD or PUD. And this may be beneficial for up to 1/3 of patients with functional dyspepsia. The last strategy is the empirical anti-secretory drug therapy. Most studies have shown that PPIs are the preferred drugs for the treatment of dyspepsias, and they are more superior to H2 receptor antagonists. And economic analysis indicate that the empirical anti-secretory therapy may be more cost-effective. The disadvantage, though, is that rapid symptomatic relapse after therapy is discontinued and the potential for rebound gastric hypersecretion. The general measures for treatment are as follows. First, reassurance and education is of primary importance in patients with functional dyspepsia. Lifestyle and dietary measures should be taken into consideration, and patients should be allowed to eat more frequent and small meals, avoiding high-fat meals, for the simple reason that high-fat meals may delay gastric emptying, aggravating the patient's symptoms. Patients should be discouraged from consumption of spicy food containing capsaicin and other irritants. Coffee may aggravate symptoms, though in some cases, if implicated, should be avoided because studies have shown that coffee does not cause dyspepsia. Cessation of smoking and consumption of alcohol has not been proven to be helpful. Avoidance of aspirin and other NSAID has no established value. If patient has an apparent coexisting anxiety disorder or depression, appropriate treatment should be instituted. For the pharmacologic treatment of dyspepsia, acid suppression is still the mainline treatment of choice. PPIs are more efficacious in controlling dyspepsia than H2 receptor antagonists. The next treatment would be eradication of H. pylori using a triple therapy for eradication. We must be aware of the presence of resistance among the antibiotics given, most especially amoxicillin and metronidazole. In the eradication of H. pylori, we should recognize the fact that certain antibiotics such as amoxicillin and metronidazole have high resistance in certain areas. And so we should choose the right antibiotics for the eradication of H. pylori. A meta-analysis of various RCTs favor eradication of H. pylori in patients with functional dyspepsia. In this meta-analysis, it has been reported that 9% of patients had reduction in the frequency of their dyspeptic symptoms after HP eradication compared to placebo at 12 months of follow-up, with a number needed to treat of 12. Other arguments in favor of the use of eradication therapy are protection against PUD, presumed protection against gastric cancer, and the short-term nature and relative low cost of treatment. The other drugs for the treatment of dyspepsia include prokinetic agents. There are a few prokinetic agents available in the market, although there are no good data on the effects of prokinetic agents in the management of dyspepsia. The other agents that may be offered to patients with dyspepsia include those that enhance gastric accommodation. One of these drugs is the 5-hydroxytryptamine 1A agonist buspirone, where it was found out that it alleviates epigastric pain and discomfort independent of changes in anxiety and depression levels. Agents that enhance gastric accommodation are good for impaired gastric accommodation, which is the most common found abnormality in functional dyspepsia. Buspirone has been shown to improve both symptoms of early satiation and gastric accommodation without effects on anxiety to explain this. The anxiolytic 5-hydroxytryptamine 1A buspirone improve both symptoms of both satiation and gastric accommodation without effects on anxiety to explain the symptomatic benefit. When all the pharmacologic treatments directed in the GI tract do not work, then we should shift our attention to the psychiatric makeup of the patient. We can provide patients with antidepressants, anxiolytics, and antipsychotic drugs. The rationale for their use is their ability to alter the pain processing pathway in the brain. And they have a centrally acting neuromodulator effect. In a meta-analysis, it was confirmed that centrally acting neuromodulators may be effective for treating functional dyspepsia. Also, in a multi-center trial in which patients with functional dyspepsia were randomized to treatment with placebo, amitriptyline, or escitalopram for 8 weeks, only amitriptyline resulted in symptomatic improvement, which was confined to the subgroup characterized by epigastric pain, or the EPS-like subgroup. The following are the recommendations for the management of dyspepsia. Take into account specific aspects of a patient's case and weigh several risk-benefit factors. In a young dyspeptic patients, meaning those 45 to 60 years of age without alarm symptoms, initial endoscopy cannot be recommended because the yield is low, and the test is unlikely to lead to improved outcomes. Endoscopy can be reconsidered, however, if the patient is worried about an underlying disease, or if that patient has a family history of cancer, or has emigrated from an area with high incidence of gastric or esophageal cancer. Here is an algorithm for uninvestigated dyspepsia taken from the textbook of gastrointestinal and liver disease by Schlesinger. When you have a patient with uninvestigated dyspepsia under the age of 55, you may start with empirical therapy with a PPI, or you may opt to do a test and treat for H. pylori. And if the patient responds, then you just continue this treatment. However, if the patient's symptoms continue to exist, then consider a prokinetic agent. And if there is no response, this patient should undergo endoscopy to rule out an underlying organic cause. Among patients who are above 55 years of age, endoscopy is recommended. And 70% of these patients will have no underlying organic disease, and we term that functional dyspepsia. Those with organic causes should be treated accordingly in accordance with the nature of the illness. Those with functional dyspepsia, we should distinguish those with postprandial distress syndrome and those with epigastric pain syndrome. For those with the postprandial syndrome, a prokinetic agent may be the more appropriate drug to give, and this can be combined with a PPI. If the patient improves, then just continue the treatment. However, in certain conditions where patients do not respond well with a prokinetic agent and a PPI, Pacotinamide, if available, should be given. Now, if the patient has early satiation, a 5-hydroxytryptamine 1A agonist is a better option. And if the patient develops weight loss due to the dyspepsia, mirtazapine will be a better option. If patients will be refractory to this treatment, a gastric emptying study should be performed. And if it is established that there is delayed emptying, this should be treated as gastroparesis. Among those with epigastric pain syndrome, after eradication of the H. pylori, if it is positive, then PPI would be the best treatment of choice. And this can be combined also with a prokinetic agent. If treatment fails, then amitriptyline should be started on these patients. And if patients are refractory, maybe hypnotherapy or psychotherapy and nutritional support should be given to these patients. Let me just discuss with you the recommendations for the management of dyspepsia as proposed by the American College of Gastroenterology and the Canadian Association of Gastroenterology. The first recommendation is that we suggest dyspepsia patients aged 60 or over have an endoscopy to exclude upper gastrointestinal neoplasia. Take note that these patients should be over 60 in age. The recommendation is a conditional recommendation with very low quality of evidence. We do not suggest endoscopy to investigate alarm features for dyspepsia patients under the age of 60 to exclude upper GI neoplasia. Again, this is a conditional recommendation with moderate quality of evidence. The next is, we recommend dyspepsia patients under the age of 60 should have a non-invasive test for H. pylori and therapy for H. pylori infection if positive. Here, the recommendation is strong with a high quality of evidence. The next is, we recommend dyspepsia patients under the age of 60 should have empirical PPI therapy if they are H. pylori negative or who remain symptomatic after H. pylori eradication therapy. Again, the recommendation is strong with a high quality of evidence. The next is, we suggest dyspepsia patients under the age of 60 not responding to PPI or H. pylori eradication therapy should be offered prokinetic therapy. The recommendation, though, is conditional with a very low quality of evidence. We suggest dyspepsia patients under the age of 60 not responding to PPI or H. pylori eradication therapy should be offered TCA or tricyclic antidepressant therapy. The recommendation is conditional with low quality of evidence. We recommend functional dyspepsia patients not responding to PPI or H. pylori eradication should be offered TCA therapy. Again, the recommendation is conditional with a moderate quality of evidence. We suggest functional dyspepsia patients not responding to PPI, H. pylori eradication therapy, or tricyclic antidepressant therapy should be offered prokinetic therapy. The recommendation is conditional with very low quality of evidence. We suggest functional dyspepsia patients not responding to drug therapy should be offered psychological therapies. Again, the recommendation is conditional with low quality of evidence. We do not recommend the routine use of complementary and alternative medicines for functional dyspepsia. The recommendation is conditional with very low quality of evidence. We recommend against routine motility studies for patients with functional dyspepsia. Again, the recommendation is conditional with very low quality of evidence. We suggest motility studies for selected patients with functional dyspepsia where gastroparesis is strongly suspected. The recommendation is conditional, also with a very low quality of evidence. So let me now just show you the algorithm for the treatment of uninvestigated dyspepsia. When you have a patient who is above 60 years of age, endoscopy should be offered as the initial strategy because the presence of organic pathology among these age groups is high, and patients should be treated accordingly to what is seen on endoscopy. If it is normal, then we should manage this as a functional dyspepsia. For those who are less than 60 years of age, we may test and treat for H. pylori. If the patient is positive, eradication should be performed. If it is negative, then patients may be started on PPIs. If it is successful, then just continue the PPI. And if it is unresponsive to the PPI, a tricyclic antidepressant should be offered, or a prokinetic agent should be added to the PPI. And if no response is seen in these strategies, then consider psychotherapy. For patients who have been diagnosed to have functional dyspepsia, if the H. pylori is positive, then it should be eradicated with a triple drug therapy. And if there is no response, a PPI should be added to this treatment regimen. If the PPI plus the H. pylori eradication treatment is unsuccessful, then a tricyclic antidepressant should be the next treatment strategy. And if there is no response, maybe a prokinetic agent may be started. And if all these strategies have failed, maybe a psychotherapy should be considered. I think this is the last of my slide, and I'd like to thank you for your kind attention.